Okay. Did that give you all the update that it is indeed recording? Thumbs up? No?
Yes, it did.
It did. Perfect. Okay. Thank you. For some reason, it did not give me the update on my side. All right. So welcome everybody. So today, for the PQC educational series, we are going to be talking about caring for cardiac conditions and pregnancy, both procedures and project updates. And so Dr. Meyer is going to be leading us today. Um, Actually, Marge, I'll have you advance the slides now that you're
Yeah,
in control of
yeah,
this.
yeah, yeah. I'm fine too. And thanks, guys, as usual. I guess she'll have the housekeeping, but please feel free. I can't see the chat. We'll get to them later, but feel free to ask questions. Anyway, Sam, I'll let you do housekeeping.
All right, so for housekeeping, same as with most of our webinars, you are welcome to use the chat function. Um, this time around, I will be monitoring that, and I can interrupt Marge for those questions. Your microphone should have been muted when you joined. If you would like to verbally ask your question, please just unmute yourself. And then we do have the automatic captioning. So if you look for your show captions option in your navigation bar, you're welcome to use those. We do have an evaluation, so if before the event, please feel free to complete that evaluation. The QR code is here. We'll redisplay that later at the end of the webinar today as well. All right. Oh, yes. So our standard acknowledgement that this particular webinar is part of our AIM work, which is funded by HRSA. So please note that everything in this webinar is the views of the presenter and team, and not necessarily the official views of HRSA or the government. And no disclosures. All right, turn it over to Marge.
Okay, so I want to just level set. We had the AIM rollout for cardiovascular disease. You'll see a couple slides that are similar, but I wanted this particular one to maybe I thought of it because we've been spending so much time talking to your various emergency departments, but I wanted this one to pretty much be all of you guys are going to be called down to the emergency room with a patient with some acute cardiovascular symptom. And the goal of this particular talk um, is to just give you a framework so that you can understand what the ED is doing. You can put it into context of your pregnancy, and you can, when they look to you and say, can we, because that's what they're going to be doing, to give you some comfort and some reassurance about how to do that, even though, of course, you can always call us. So just to remember that pregnancy, labor, immediate and later postpartum periods are all unique and different in terms of cardiovascular stress. The reality is over the course of the pregnancy, as everyone knows, there's a huge increase in cardiac output and heart rate. And people feel this, right? We've talked to all of our patients. They all say, I can hear my heart pounding in my ears at night. And there is some concern about that. Remember, your plasma volume essentially goes up by at least 50%. If you have twins, it literally goes up by double. And so, but these profound changes actually are pretty early, even though you might hear people complain about them mostly in the third trimester. Most of your cardiovascular expansion is complete by the beginning of the third trimester. So it really precedes this huge amount of fetal growth. And so this is all really preparatory. Now, what happens after delivery, however, especially in that first hour, is really critical because you have a gigantic increase in cardiac output. And so, if you were to identify the times that people are going to get into these cardiovascular stressful situations, it's going to be around the middle to the end of the second trimester, and then immediately postpartum. Um, basically cardiac output, it goes up by half again, almost double, where it mobilizes a huge amount of fluid. Remember, the uterus contracts, there's an auto transfusion of all of that myometrial blood. It's gigantic volume hit. Um, and we normally adapt by increasing our cardiac output. And this is super good and probably evolutionary. It's super helpful. It's probably why people don't bleed to death as much as we think they probably should. They've got a little extra volume, they mobilize it, and it keeps them from dying of hemorrhage. So, what we're going to go through today, I know that we've already gone through screening, but I'm going to remind you and reassure you that you actually probably are screening for cardiovascular disease in pregnancy. As you know, I'm very sensitive about not giving you a lot of different forms to do. The response you can do, but mostly I'm going to talk about specific ways that people might come to the emergency room with some common cardiac conditions so you can have a framework. So remember, in terms of screening, I've already heard people are worried, are we screening? Is there a tool? I try and make sure that people are aligned by your H&P. You all know how to do an H&P. That is actually your screening thing. Do you have a medical history of cardiac disease, palpitations, arrhythmia, right? We're asking people these things at most, certainly at their initial visits and later. And if you're having a nurse or somebody that, or even an MA that's doing some of the initial pregnancy visits, it is true. You should always ask everybody, your own self, about their cardiovascular diseases. But the red flags, as you know, are any kind of prior cardiac disease. If they're like, you know what, I'm always short of breath, that's not counting people that are pregnant, as you know, they always complain of being short of breath. If they can't lie down flat when they sleep, if they have a resting heart rate over 120, if they have resting hypertension, if they have a resting respiratory rate over 30, or if they're desaturating less than 94%. These are all red flags, but these are pretty red flags. I don't believe that most of you guys are going to miss any of these things. It is important to assess for risk factors. That would be largely age, if you're African American, especially people with chronic hypertension or diabetes. And as you know, there are a lot of people with not really great control of hypertension or their diabetes. BMI at 35, I would say that's like 100% of our population almost. So it's hard to say that's a huge risk factor. Um, History chemotherapy goes in between. We're always happy to see them. Obviously, doxorubicin can cause heart disease, but most people do really well with that. They're super careful now about dosing these things, and certainly substance use disorder, especially cocaine. And again, obviously, baseline shortness of breath, asthma that's not well treated or not responsive to current therapy, and obviously current symptoms. Um, these are the different risk factors that are for the red flags, but you'll see why in a minute because it has to do with whether or not it's kind of normal or a green or yellow or red problem. But when you screen, there are a lot of people that are going to screen positive as high as 15%, but really very few people are going to be truly positive with a cardiovascular disease. And remember, this comes from the ACOG 2019 bulletin, which I think is still just a great framework to think about in terms of when you can consider just routine care when you see people, what things might require some non-urgent evaluation and what things might be quite more prompt. And remember the goals of screening. It's going to identify their baseline and whether or not they've got a lot of comorbidities. Remember, everybody um, should have their heart rate and respiratory rate checked each visit. We don't check the O2 sats every visit, but certainly if people have asthma or underlying disease, and just be alert for changes. And again, a good hint is if a patient has a change in their daily living. Yeah, which is just non-emergent evaluation. It's really pretty persistent symptoms, and you can send them to us, you can send them to their family medicine person, you can refer them to cardiology if you like. Those are people you might want to get a baseline EKG or BNP. Remember, BNP is natriuretic peptide, and it is a measure of volume. You're going to see that come up in later slides. I have a pretty low threshold to get baseline EKGs on people, especially with long-standing diabetes or hypertension. If they're red, if they have something that is concerning for cardiac disease, just send them to us. And anybody with obviously poor control of pre-existing diabetes or hypertension, but I find most people in the state are already, and sending those people to us. So this is the basically, pregnant person walks into your unit or the ED with. And I'm going to assume that you already know how to diagnose preeclampsia and infection. So this is going to be specifically for people that you're not like, I'm pretty sure you just have preeclampsia or you're infected. And the main symptoms people are going to present with are going to be chest pain, shortness of breath, dizziness, and palpitations. We can all know dizziness and palpitations are so common. We're going to talk about that. And also, as you know, in almost every triage, anybody who comes in with these things, you're going to get a set of vitals. And so these are the high risk vitals: heart rate over 110, respiratory rate over 24, systolic blood pressure over 140, and O2 sat less than 96. If they have any of these, even if you're not sure, but if they present emergently, I'm going to assume that their dizziness and palpitations, if they're coming in for an emergency visit, as opposed to say they might walk into your office and say, I occasionally feel X, you can get some things done. But if they walk in with an emergent concern of these things, go ahead and you can start just sending off as you're getting them settled a metabolic profile. This is going to give you an idea. Are their kidneys working? Are their electrolytes normal? A BNP, again, that's the natriuretic peptide, is going to give you an idea of their volume. And these are the ones, a D-dimer troponin, or depending on how worried you are. If they really are like, I have terrible chest pain or shortness of breath, go ahead and send them off. And at the same time, go ahead and get your EKG. And you can decide on a chest x-ray, which is only sometimes helpful if you think there's a pulmonary process, and you can listen to their lungs. So you don't have to get a chest x-ray on everybody, but have it on your list just in case. And again, there are really 4 super common things that we might see in the emergency setting that you don't want to miss. And that's going to be an arrhythmia, an MI, or some kind of, or I should say, acute coronary symptom, a PE, or heart failure. And this one evaluation will help you distinguish between all of those and give you some confidence about how to move forward. So to find any of these things that are super scary diagnoses does not take a lot of testing. It just involves sending stuff off that you might send off very commonly anyway. So especially if you're in the emergency setting, which a lot of people, this is where they're going to be up in the ED. The good news is your emergency department already has protocols that can address these things. And they are in the best place to stabilize and care for them promptly. They'll call you, and we will just go down to the ED, consult cardiology if you need it, and of course, eventually call MFM. But depending on how sick they are, as you know from our stroke teams, people have a saying, time is brain, right? There's lots of stroke protocols to emergently assess people with a stroke so that they can get those reperfusion interventions done. And really, the heart is the same. Time is muscle. So you don't want to be behind um, on making these diagnoses. So these are the key labs that are going to tell you where you live in that differential. And arrhythmia is going to be, first thing they're going to put somebody on EKG, they're going to figure that out. The metabolic profile and the BMP in those settings, they'll come eventually, but your diagnosis is going to be made by the EKG. Myocardial infarction, similarly, will be made by an EKG. Most people, obviously, some people don't have EKG changes. That's why you go ahead and send off the troponins. But most people, those things are, your EG has processes. They will send those around and they will get them back quickly. Pulmonary embolus D-dimer, which I'm going to show you the D-dimer data. That's going to be much more important. And heart failure and cardiomyopathy, but people will know that because people will look like they're in failure. Their lungs they'll have pulmonary edema. They'll have an oxygen saturation. These are things that are going to be identified pretty quickly. So these are obviously not in the order of my initial things. So what about if they have an acute myocardial infarction or an acute coronary syndrome? Acute coronary syndrome is really any acute heart thing. Acute myocardial infarction is just a part of that. Again, you're going to order these same labs, but this is one of the most important things is that every postpartum patient with chest pain, you need to think about an acute coronary syndrome or myocardial infarction. So acute coronary syndrome implies that you have a suspicion of myocardial oxygen deprivation that's leading to myocardial injury. That's going to bump your troponins. Myocardial ischemia causes both angina and myocardial infarction. But the most common pregnancy-associated cause of acute coronary syndrome is spontaneous coronary artery dissection. And that is unique to pregnancy. And this is something that you can remember and bring to the table for your ED because while it is associated with ischemia, it can be harder to diagnose, and it's not uncommon within a week postpartum. So what your testing findings are going to be, you're going to see changes on your EKG, although remember that pregnancy can cause some nonspecific STT weight changes. You're going to see high troponins, but they're going to be coming back. And if you're immediately postpartum or preeclamptic or have a PE, your troponins can be slightly elevated. I hear the ED terms are troponin leak. Those are mild elevations of troponins. So troponins can be a little tricky. BMP is brain natriuretic peptide, the BMP, and some use an the N-terminus pro-BNP, your ED will know, but basically, whenever they talk about any of the natriuretic peptide, that elevation is suggestive of heart failure. It goes up in pregnancy, as you might imagine, because your left atrium and right atrium dilate in response to the volume, but it's usually still in the normal range. We'll see BMPs of like 3,500. They'll be very, very elevated in the setting of failure. So spontaneous coronary artery dissection is not the same as an atherosclerotic plaque. If you have atherosclerosis, you have narrowing. This is chronic. You have lipid in your vascular walls. When you have a spontaneous coronary artery dissection, you have blood that's going through your coronary arteries just like it should be. But what happens, probably you have some vasospasm or some other injury that literally lifts the lining, that endothelium off of the coronary artery. And so blood gets underneath this lining. And this is what in the nature is of a dissection. And so you develop actually this hematoma in the in the vascular wall. But of course, it's coronary artery, so it's very narrow, so it creates some ischemia. These actually often heal without intervention. Our guys in the cath labs can oftentimes get a sense of whether or not it's an atherosclerotic plaque or dissection. And while it can be difficult it's almost impossible to differentiate without a cath. This is why you'll see that people who have chest pain and EKG changes and suggestions of of acute coronary syndrome or an MI will need to go to a cath lab. They are not going to get transferred to me to go to the cath lab. That needs to be done immediately, and it's going to be done probably at your institution if they do caths there. And I meant to look up if there's any place that doesn't do caths, but I forgot to look. But again, the timing is so important. I've been called when people are like, okay, this lady's leaving the cath lab now and she's 35 weeks pregnant and had an MI. So they won't call me before either. They take them immediately to the cath lab. Troponins are myocardial proteins. They're very sensitive and very specific for myocardial injury. There are high sensitivity assays now, and they assist in the most rapid diagnosis of myocardial ischemia. And it can be slightly elevated postpartum. So you can't, the amount of the peak matters. And this actually just goes to show you, this is when you have a STEMI as a ST elevation MI. That means you see EKG changes. You can see these troponins, they are high, right? If you have no ST changes, this is non-STEMI, which is you don't have ST segment changes, but you still have elevations in your troponin. They're not as high, and these do seem to correlate roughly with myocardial injury. You can get things, again, labor, preeclampsia can increase it, myocarditis can increase it. Here's running a marathon, in case you're thinking about doing that. And even PEs can increase it slightly. So I don't want you to think that, but if you're just in heart failure, it will really bump your troponin. So the ED people, they are all over this. They use this every day and can help you interpret it. But this is why they're getting it. You do get it at presentation at 1 and 3 hours. Usually you can make a diagnosis of myocardial injury very quickly and get into the cath lab. And again, the trajectory can change over time. So basically, no matter what the etiology, the whole point of the whole goal of treatment is going to be coronary flow restoration. So in this setting, pregnancy, as you'll see, this is a recurrent theme. Pregnancy does not change the approach terribly much. You get medical management, right? They hit the door, they've got chest pain, the nurse is putting on the oxygen, the docs are handing their beta blockers, they're sticking on a nitro patch, they're giving them a full aspirin, which is fine. They might give them some heparin, and they're going to block them down. When, again, the pregnancy specific things are, of course, going to be, you want people to be positioned to keep their cardiac return optimal, which means they're going to be on one side or the other and not on their back. If it's feasible, you start fetal monitoring, but if they're not viable and if it's not feasible because they're on their way to the cath lab, let the cath people do their thing, because the main treatment for mom and therefore the main treatment for baby is going to be restoration of coronary flow. If they're going to the cath lab and they're viable and you want to give them a shot of beta-methicillin, feel free. When they go to the angio unit, you can expect that they might balloon them. And if they see an atherosclerotic stent, lesion, they may even place a stent. I don't get into great detail about the stents. When you use a stent, though, people need to be on these platelet inhibitors, which are which are very high risk for bleeding, but we can manage that um, down the road, if you will. If there's a dissection, if they do a cath and they think that there is a dissection, they won't do anything. And they'll transfer. And if they can't do a cath, then they'll transfer to the closest cath lab. But the goal is from the door to having a balloon or a stent within 90 minutes. So again, these things might happen all before you even know about it. Because maternal coronary perfusion is the priority. Once they get back, then of course you can start their routine care, and we can all catch up, take a breath, and talk about their standard medical care, which is mostly going to be oxygen, aspirin, sometimes heparin, and beta blockers, and sometimes these antiplatelet meds. And sometimes you're going to not monitor a fetus until they're back. So can't talk about an MI without talking about perimortem section. I know that most of you guys have had, I also have slides at the very end about this. But basically every ED should be prepared for perimortem sections. You can start at 4 minutes, but I think it's important for you to know that you can do them and it will help the mom's outcome, if not the baby's, if all the way up to 25 minutes. You empty the uterus as long as that uterine size is more than at the umbilicus. And that is true whether the baby is viable or not. Emptying the uterus seems to help with their return to circulation. It's the resuscitative hysterotomy or perimortem section is done at the time, and where the CPR is being performed, you just continue the CPR and then you obviously notify resuscitation. I have slides on this a little bit later and we can talk about this, but I know that everybody is actively drilling these things. I will tell you that it is important to have a framework about how you're going to get this done. But again, realistically, it's going to be your ED people, unless you already know somebody's coming in with a code, because it needs to be done in such a short period of time. And that's why we're working with the ED people. So what about arrhythmia? These are super common in pregnancy. People complain of palpitations, their premature atrial contractions and premature ventricular contractions happens all the time because you have this big volume load, fills up the ventricle, especially stretches out the atrium a little bit. So you fire some of those nodes a little early. People are more likely in pregnancy to go into SVT, although most people who have SVT in pregnancy have had it before. AFib and AFib are possible but less common, but are worthy of conversation. So again, exactly the same evaluation, although if they have an arrhythmia, I always do a double check of their thyroid functions. Palpitations, premature atrial and ventricular contractions are benign. They're super common. Most people will have had a history of a severe arrhythmia if they've had it before, but it can be associated with a pulmonary embolus or cardiomyopathy, so we always look around. And of course, some people have inherited arrhythmia syndromes. Oftentimes they'll come and know about that, so they're most commonly prolonged QT or WPW or Wilk Parkinson White. So again, always check for electrolytes if somebody has a new onset of cardiac arrhythmia. And in one study, mostly people need to be reassured. They will feel irregular beats. Their wearable devices will tell them they're having irregular beats. And almost a quarter of pregnant people will have palpitations, but only 10% of those. That's only a quarter of pregnant people, and only 10% of those people will have an arrhythmia. If symptoms are intolerable, and we have a lot of people with intolerable sinus tach, and I just want to comment on that because I think that is the training effect of pregnancy. Is because people, if you're deconditioned, you will definitely have more sinus tachycardia in pregnancy because pregnancy is like a conditioning state and they are not prepared for it. But we see this all the time. And if it is really intolerable to people, you can use a low dose of beta blocker metoprolol. Usually, most of our patients can get by with 25 a day just to keep their heart rate down so it's not so uncomfortable. And it's strictly symptom control. So if somebody presents with palpitations, go ahead and get your EKG, go ahead and get your targeted blood testing, which really, if they just have palpitations and you're not that worried, just get a BMP and a metabolic profile. Obviously, you need a chest x-ray. EKG, you don't need a chest x-ray, but definitely check their thyroid functions. Um, and then if they just have sinus tach or extrasystole, you can just reassure them. Obviously, if they have SVT, AFib, or A-flutter, then obviously you're going to need to get your emergency room people and your cardiologist to help you with that. The treatment, it's not so different from the MI. What you want to do is manage hemodynamically significant arrhythmias and the most effective therapy that's going to fix the arrhythmia. So you don't want somebody to be cardiovascularly unstable with an arrhythmia. That can be vagal maneuvers. A lot of people that have had SVT will know how to use those medications. Basically, the medications that you use to break an SVT, things like okay, I know the answer to it, but I'm just like blanking on the most common medication because I want to say atropine, but that's not correct. Adenosine, thank you.
Adenosine, yeah.
Yeah, adenosine. Um, and I don't know if you've ever been when somebody's been medically cardioverted, it's a little disturbing because they give the adenosine and then their heart just stops for a while and then eventually picks back up. But don't hesitate to use cardioversion if it is necessary. And I think that's really the take-home point. If the cardiologist feels that whatever the rhythm is, that it's shockable, and that's going to be the fastest way to get to terminate the arrhythmia, then that's the way that you want to go. So definitely try the vagal maneuvers if they're stable. Again, you can just start with the adenosine. You can also use a beta blocker if you can't use the adenosine. But you do want to use cardioversion. You want to avoid the breast tissue because it's so thick. It interrupts the current. And generally, anesthesia is recommended to protect the airway. All of that can be done in the emergency room. They can intubate somebody and they can cardiovert them if they need to. You obviously, you will eventually need to monitor the fetus, but again, mom has to be hemodynamically stable for the fetus to be okay. So focus on that. Focus on having a hemodynamically stable patient, and then you can move to your fetal assessment. If the EKG is suggestive of a prolonged QT syndrome or Wolff-Parkinson-White, or they know they have a history of it, it's always important to know. And this is why getting your family history, a personal history of arrhythmia, and a family history of arrhythmias, and also even sudden death, since that's often how prolonged QT is identified. Remember, prolonged QT is an autosomal dominant disease. Beta blockers may be indicated prophylactically, and if people have prolonged QT syndrome, they often are on beta blockers during their pregnancy. You do need to avoid specific medications like azithromycin or fluconazole. And obviously, in people who have a strong family history of sudden death, some of them have implantable defibrillators. WPW is less common. I was surprised it was less common. It seems like it's common to me. It's diagnosed that there are some diagnostic EKG changes, but they can be very difficult to figure out in pregnancy. But if they're in SVT, they actually use different medications. You don't use adenosine, you use flecainide, and they also may have ICD implantations. We do have people who are pregnant who have implantable defibrillators. It's not a huge deal. And frankly, if you have cardiology at your institution, usually they can deliver there anyway. But just know that there are these inheritable pro-arrhythmogenic EKG changes. So PE, in some ways, I think this is the most important thing because it's something that we are always paying attention to because it is definitely a higher risk for our patients. Is I don't know if your ED is using D-dimers to triage prior to doing CT angiograms, but you should. So there's really good data. People present with chest pain and shortness of breath to get your D-dimer. If your D-dimer is less than 1,000, the cutoff, if it's lower suspicion, and I'm going to show you how you sort of sort that out, or if you're a higher suspicion, if it's less than 500, these are again during pregnancy. You can use that to help decide whether or not somebody needs a CT angio instead of just CT angioing everybody. So triage, of course, starts with acute stabilization, but then you use what they call the years criteria. That is clinical signs of DVT, right? Swollen leg, redness, hemoptysis, coughing up blood. I think most people will find that symptom alarming. Or if you're like, PE is by far the most likely diagnosis, which means a very high level of clinical suspicion, often based on their vital signs, their O2 sats, and their presentation. So these are the data. They're very well validated. This is from 2019. So you do not need a CT angio if you do not have any of the years criteria. That is, you don't have a known DVT, you don't have hemoptysis, and you really think that they have a pretty low risk situation of a PE, and your D-dimer is less than 1,000, then you don't need to get a CT angio. If you just have 1 to 3, which would be sort of all of them, and your D-dimer is less than 500, you also don't need to get a CT angio. You have something else going on. You do need to get a CT angio if your D-dimer is over 1,000, or if you have any of these criteria and your D-dimer is over 500. If you follow this algorithm, you will be able to avoid about half of the CT angios that we do. So I don't know if everybody's institution is using D-dimers, but it is an important piece to avoid doing angios on everybody. Just recently, they published this validation of a similar protocol in postpartum women, only the D-dimer cutoff is much higher. That's partly because if you have a DVT postpartum, you're going to have much higher D-dimers. And if you're immediately postpartum, your D-dimer is going to be up at around 1,000 anyway. But basically, again, you can use the same years criteria, clinical sign of a DVT, hemoptysis, or PE being the most likely diagnosis. And you can use the D-dimer to differentiate whether or not you need to get an angiogram if it's over 5,000, or if they're don't have a high respiratory rate and their D-dimer is low, to avoid it. If they have, this also uses some scoring systems in terms of what your risk assessment is for DVT, specifically based on weight, cesarean, and if you had a postpartum hemorrhage. And I'm just going to remind everybody that by far the biggest risk factor for a postpartum PE is having had a postpartum hemorrhage. The relative risk attributable to postpartum hemorrhage is like tenfold, as opposed to even cesarean, which is like 3 to 5, or a high BMI, which is maybe 2. So by far, postpartum hemorrhage, that should put you into a higher risk mindset. But you can still consider using the D-dimer and the respiratory rate to decide to not get a CT angio. So I really strongly encourage using the D-dimer to help differentiate in pregnancy and postpartum for PE. So remember, therapeutic anticoagulation, you do not need to use IV heparin. You can start low molecular weight heparin. It's super easy. It's just 1 milligram per kilo twice a day. But obviously, if they're hemodynamically unstable, sometimes those people need a thrombectomy. If they have right heart failure, they're going to need to go to a referral place and get it. But again, you can start their anticoagulation, transport them, and then get them thrombectomy if they're having some cardiovascular instability. Cardiomyopathy also should be something that's fairly straightforward to recognize. They're going to come in with chest pain and shortness of breath, but they are going to be wheezing. So you know what? I didn't put it on this slide, but what I always tell everybody is, unless you have a known history of asthma, and even then you should worry. Anybody who is postpartum, who is wheezing, has pulmonary edema until you are sure that they don't have pulmonary edema. Because albuterol does not treat pulmonary edema and overload very effectively, and yet it is frequently the first drug people are exposed to. So their BNP, their naturopathic peptides will be elevated. They can have a low O2 sat, but remember, our patients, they're healthy, they'll breathe super fast, and they can keep their PO2 up on the curve. Once, if you see somebody that's breathing pretty fast and their sats are starting to fall, they're like in that 95 and then maybe 94 in the high 90s range, they are working really hard to keep that up, and they have got something going on, oftentimes pulmonary edema. So regardless of the etiology, the initial treatment is super important. And if you have somebody on the floor that's all of a sudden short of breath and wheezy, everybody postpartum could use a little Lasix. Go ahead and give them 20 IV Lasix and then sort it out on the other side. So start with diuresis, and if they're hypertensive, make sure you reduce their afterload. Antepartum, you can do nitrates. Some people say that nitroglycerin actually does help the pulmonary venous vasculature, but we don't have those on the floor that much, so I wouldn't worry too much about it. I would use hydralazine or nifedipine. Postpartum, I wouldn't use an ACE and an ARB. I don't think you need to. Mostly you can use the same labetal hydralazine that we usually use. And once you know that once you get their diuresis under control, then you start thinking, well, why do you have heart failure? And that's where your echo comes in. You see what their ejection fraction is. If they have low ejection fraction, you do use anticoagulation. And I just wanted to let people know that we have other fancy tools now that are brand new here called ECMO if people really have terrible heart failure. For those of you that don't know about ECMO, it's extracorporeal membranous oxygenation. We just got it here. And they obviously, they need to be here. They have to be really sick. What do I think? I think I've seen maybe one patient in my career that is a candidate for ECMO. The most common times people have had it and the most pregnancy experience, frankly, is with COVID, is when people's lungs were bad. But I just wanted to let you know that we do have ECMO here. We plan on, if we think people's cardiac status is equivocal enough that they might need ECMO at some point, especially postpartum, we will not deliver them here. We'll send them to a quaternary institution. But we have it here for emergencies. So I wanted you guys to know about our pregnancy heart team. I wanted you to know that what our structure looks like here. We have a regular group that meets. It's MFM cardiology, anesthesiology, and our nursing teams. We do all cardiac planning. We go from antepartum, intrapartum, and postpartum. And we have a multidisciplinary conference for anybody that's complicated. We have a highly structured note. You don't have to look at everything on here. I wanted you to just be impressed about how long this note is. This is our cardio OB delivery plan. We start out with risk stratification. Remember, we did that in the other talk about all the different ways that you can classify maternal cardiovascular risks. We talk about what their disease is. We talk about what we're doing intrapartum. We talk about how we're going to manage their fluids. We talk about what they need postpartum, including telemetry. We talk about their postpartum IV access. We talk again about postpartum fluid loads. We talk about how we're going to deliver them. Anesthesiology has a plan about how they're going to do their anesthesia. And nursing, of course, and pediatrics has a plan. So we have a very comprehensive note. We go through it all together. And so just to remind you that this, though, is the basis, I feel like, of your cardiovascular experience. And really watch out for people who've had very long-standing, poorly controlled hypertension. I am very worried about those people, and I'm worried about people who've had long-standing, poorly controlled diabetes. But of course, you guys already send them to us. So this is just a summary slide so that you can get, again, a framework in. And the take-home message, I have more slides. Great. About this, but basically call us. But in general, the treatment in the ED is not going to change a lot for your pregnant people. They need to be stable, regardless of the status of the fetus. We can always catch up later in terms of what's going on. Restoration of maternal hemodynamics is super important. I wanted to make sure everybody knew we actually have a new clinic, and we are referring all people with hypertensive disorders. I think many of us would like to see this for more, to expand to more people with other medical problems, to see them 3 to 6 months postpartum. This is a clinic that was initiated by one of our fellows, Dr. Vasudeva. She did a part of her thesis, and it's ongoing and been extremely popular. And basically, what she does is we talks a lot about what their cardiovascular disease was and what it meant at the time. She kind of debriefs their pregnancy a little bit. She moves forward to a next pregnancy, and she talks about nutrition and cardiovascular follow-up. And they do a lot of lipid testing, diabetes screening, and really trying to understand, to give people a good sense of what their underlying cardiovascular risk is. Over the last year, she's seen about 100 people, and she goes through a course, Life's Essential 8. I think actually I had this in my original slide. Sleep, psychological health, support for smoking cessation, and exercise. So these are the people that she's seen. She's seen 22 people with gestational hypertension, 27 preeclampsia without severe features, 39 with severe features, and 6 with chronic hypertension. So these are all the people. Obviously, there are quite a high prevalence of people with persistent hypertension. And during that clinic visit, she did initiate a hypertensive management, not an insignificant number of times. Not surprisingly, she did identify a number of people who had abnormalities in their LDL, and especially hypertriglyceridemia. Obviously, some of the patients are a higher risk for diabetes, especially these people that have chronic hypertension and other cardiovascular risks. So she had 4 new people that were diagnosed with hypercholesterolemia, 14 with hypertriglyceridemia. And of interest, if you had an SGA infant, you had lower triglycerides and glucose, then those are the appropriately grown infants. I didn't see these necessarily corrected for their BMI. I suspect that there might be a correction in there. You can also imagine that preeclampsia might play a confounding role. But mostly what she does, these are actually from Kayla, to make sure that you guys have modules and cool toolkits. Of course, we have the AIM Cardiac Conditions Safety Bundle. ACOG has heart health documents. There's the American College of Cardiology Toolkit. We have the AIM drill packet for cardiac arrest, which I guess got taken out of here. And ACOG's maternal, and then this webinar. And This is from Kayla. We have an escape room with cardiac cases, and there's a cardiac conditions module for the nursing staff, which will be coming in a bit. So these are patient-facing resources. I think a lot of you guys probably already have some of the discharge planning materials, especially from with respect to preeclampsia. And great. So now we can just go to any questions or anything that anybody wants to talk about that I didn't cover.
Yeah, thank you, Marge. So, in addition to the questions and comments, want to also invite if you all have any resources that you all rely on or know of, want to share out, as well as any initiatives that's happening in your hospital, that would be great. And also, I'll be monitoring the chat as well.
Do you guys get called down to the ED if they have a pregnant person down there?
And it looks like we have one yes. And thank you because this is very helpful.
Is there anything that you guys were wondering about that we didn't cover?
I think this was great, Marge. This is Anna. I'm excited to share it with our ED teams to see how we align with your recommendations.
Yeah, well, hopefully it'll be pretty similar since I took them right out of the American College of Cardiology stuff.
I just had a suggestion and just an observation, as an ER and a labor and delivery nurse, the knowledge base in the ED for which tubes and stuff to draw is kind of, always we know, but for labor and delivery nurses, for the reminder that they do have to draw a green top because we don't usually draw those in labor and delivery. And if we are concerned of any kind of pulmonary emboli or anything like that, that they do have to have an 18 in the AC. And that for D-dimers, they need a blue top. So just it's a little different. ER draws a rainbow, which includes those. Labor and delivery would not. That's all.
Thanks.
I have a question. Can you hear me?
Huh?
Okay. We have some patients who, like, towards the end of pregnancy, their baseline resting heart rate will be like 110, 1 teens. I've had primary care people kind of reach out to me and communicate that they're nervous about anemia. Right, which I'm like, I think, but it is an interesting thing to kind of know, like, your one of the first slides talks about heart rate greater than 120 when they're having symptoms. So if someone's asymptomatic and they're like baseline tachycardic, what kind of are your thoughts about when you do get concerned versus when you're like, they're just end of pregnancy and fine?
Yeah, and again, like you said, a lot of it depends on kind of what the tenor of their symptoms are. And again, it's nice to know that they can, it's even hard to ask if they can sleep flat, right? Which everybody says, but like most, by the time you get to be 38 week, nobody's sleeping flat. They can like, so a lot of it is clinical judgment. In general, less than 120 is not that unusual, but I've seen plenty of people walking around at 130. And a lot of it is that they're just really deconditioned. You are 100% correct to look for anemia. And I just want to remind people to pay attention to those 28-week labs because I got to tell you, our iron infusions have been very, very effective. And so it's possible that mild anemia is actually part of what's going on, but they're right on. Just look for anemia. But I think reassurance is generally the case, especially if they don't have any other cardiac symptoms. I do like to make sure I just get a no too sad. I try and get a sense of whether or not they're at really high risk for sleep apnea early on. Those kinds of things that can make them worse. But yeah, we see heart rates over 110 all the time.
Yeah. And then I missed, you were talking about increase. This is totally subject change, but increased risk of postpartum PE, the biggest risk is if they've had a postpartum hemorrhage. And I'd be kind of curious, like, if you could kind of expound on that a little bit. Is it the meds we give them kind of then autocorrecting? Is it like their physiology?
No, it's totally a physiologic response. As you know, pregnancy itself is a very prothrombotic state. And what happens, you see it with trauma too. Once you start really activating your coagulation system, it activates everywhere. It doesn't mean that you have DIC, but it just means that you are very highly procoagulant. And it's probably, like I said, it's probably why everybody doesn't bleed to death postpartum, because you think about the size of the uterine bed and the fact that there was 600 cc's a minute going through it like 10 minutes before. So it's not surprising, but it's true for trauma and any hemorrhage. It's just that your hemostatic system is way balanced in favor of coagulation.
Okay. And then you said the things kind of following it are like, I forget, you said C-section was like increases the risk 2
Oh
to
yeah.
3 versus
If you had a C-section, and then BMI.
and
So
BMI.
frequently we will have people, and again, I don't know if you have, that's why I didn't put it on here, is because I thought we had an updated one, but we need one. ACOG has a DVT prophylaxis paper, but there's not any one place that really gives you a concise, these are people that need postpartum prophylaxis. But I will say people who've had a cesarean with a BMI over 35, and or if they had a cesarean and had a hemorrhage, we have a very low threshold to use pharmacologic prophylaxis. We usually use 1 dose of Lovenox. You can use BID unfractionated heparin if you're worried in people who've had a cesarean just while they're in the hospital, and follow those prophylaxis things carefully. We actually do use, we have a subset of patients that may be very high risk because their BMI might be higher than 50 that had a section and had a hemorrhage. Sometimes we'll even extend their prophylaxis out by a couple weeks, because if you look, the New England Journal has this great graph of risk for DVT. And it starts here immediately postpartum because a lot of them happen in the hospital. Probably at least half of that risk, if maybe it might even be close to 3/4, I can't remember, is in that first 2 weeks postpartum. So we're having a lower threshold in the absence of data. I'm going to just tell you that, of extending prophylaxis in exceptionally high risk patients. And then it really trails out. Oftentimes we'll stop at 6 weeks, but there are some people that extend it to 8 or even 12, depending on what their risk is.
Okay. Thank you.
All right, thank you so much. And so I've put the post-webinar eval in the chat. Would love to get your feedback. And thank you everybody for coming today.